Dr. Thompson is an assistant professor of medicine in the section of interventional pulmonology and thoracic oncology within the division of pulmonary allergy and critical care at the Perelman School of Medicine at the University of Pennsylvania, otherwise known as my old stomping grounds X number of years ago. And it's a privilege to introduce him on the topic of current applications for liquid biopsies.
All right, thank you so much for having me. Let me share my screen here. Thank you so much for having me. I'm really excited to be here today. And thank you for that introduction, Dr. Weiss. So I'll be speaking about liquid biopsies and their current applications. And the first part of my talk is going to be reiterating, what Dr. Weiss had mentioned about just how critically important it is to perform comprehensive molecular testing in our patients to ensure that each patient can be considered for targeted therapy, and discuss really how liquid biopsies have really emerged to facilitate this process. So, as Dr. Weiss mentioned, improved understanding of lung cancer genetics has really enabled the rapid expansion of targeted therapy. So we've really moved far beyond just EGFR and KRAS mutant lung cancer, and more recently have identified a number of specific oncogenic driver mutations, that we're familiar with, such as, BRAF, ALK fusions, RET, ROS1, just to name a few. And it's really the understanding of the underpinnings of these genetic mutations that has enabled the development of targeted therapies, and really significantly in the last few years. And I've just highlighted the impressive number of approvals that have occurred just within the last 1 to 2 years. And there's several other targeted therapy options that are on the horizon. So for both patients and providers, it's really an exciting time in lung cancer. But with the advent of so many targeted therapies that are available to our patients, it becomes increasingly important to ensure that all of our patients receive comprehensive molecular testing to assess for all of these various actionable mutations. And this is actually the same survival curve presented by Dr. Weiss, again, just demonstrating that it's not only important to assess for these various mutations, but then to treat those patients with the associated targeted therapies so that these patients ultimately have improved overall survival. But we're still not doing a very good job currently in ensuring all of our patients are receiving comprehensive molecular testing. So this is some data presented at ASCO, actually just presented a little bit differently than Dr. Weiss presented it, showing that in over 3,000 advanced non-small cell lung cancer patients seen in community practices, that only 37% of those patients received comprehensive biomarker testing or next generation sequencing, as Dr. Weiss had mentioned. So we have a lot of work to do in this area. And I think it's great that patients like yourselves are here, educating yourselves and empowering yourselves to become knowledgeable about this area, because I think education is increasingly important amongst patients and providers to ensure that comprehensive molecular testing occurs. And this testing doesn't occur for a variety of different reasons. But a major challenge is that it can be difficult to access sufficient tissue for this comprehensive sequencing. So tumor tissues may often be difficult to access in patients with lung cancer. Sometimes patients may undergo biopsies, and those biopsies end up being very small and don't have sufficient material to undergo sequencing for all the various mutations that are necessary. And interestingly, we, a number of years ago, performed a study looking at over 100 advanced non-small cell lung cancer patients where comprehensive molecular testing was indicated. And actually what we found is that about half of those patients did not undergo comprehensive molecular testing for a variety of reasons. But importantly, about a quarter of these patients had a tissue biopsy that ended up not being sufficient for detailed sequencing. And this is a real problem for our patients because it not only delays treatment while you try and figure out whether they have one of these actual mutations, but they're often subjected to repeat invasive procedures over time. And so non-invasive approaches such as a liquid biopsy have really emerged as a promising tool to facilitate appropriate molecular testing for our patients. Now, I'll have to take a little bit of step back, and that liquid biopsy is actually a more general term that involves the analysis of a number of different substances, such as circulating tumor cells, exosomes, RNA, and DNA, from a variety of different sources, such as saliva, blood, and urine. But when we're really talking about liquid biopsy in the context of non-small cell lung cancer and its clinical applications, what we're really talking about is tumor cells that shed their DNA into the bloodstream, and we can detect these DNA fragments and then look for various mutations within the tumor cell DNA. And this is often referred to as circulating tumor DNA. And circulating tumor DNA consists of these short DNA fragments that are shed into circulation by tumor cells. They can be readily detected in patients with non-small cell lung cancer, and they're highly sensitive assays that enable the detection of tumor mutations in blood, even at very low levels. It has a number of advantages in that it's minimally invasive. All you need is a simple blood draw. It typically only requires 1 to 2 tubes of blood. It can be readily accessible. There are currently 2 FDA-approved, commercially available next-generation sequencing liquid biopsy tests. And these tests often have a rapid turnaround time. Usually we'll get results within 7 to 10 days, which tends to be much shorter than the time it takes to get a biopsy and get those sequencing results back. And then because it just requires a simple blood test, it allows for repeat sampling over time. So how are liquid biopsies used currently in clinical practice? Well, they're really used at diagnosis for genotyping of newly diagnosed patients with advanced non-small cell lung cancer to identify these specific actionable mutations and guide therapeutic decisions. And then it's also used when patients develop progression on targeted therapies. Liquid biopsies can be utilized to identify potential mechanisms of resistance at that time, rather than undergo an invasive biopsy at that time. And I really like this kind of schematic, looking at extraction of tumor DNA from a tissue biopsy and a liquid biopsy, really demonstrating that these are really complementary processes that enable sequencing of tumor DNA that facilitate the performing comprehensive biomarker testing for our patients. So we can ensure that all patients have the opportunity to receive these targeted therapies. There was just a recent paper put out in the Journal of Thoracic Oncology highlighting some of the advantages and disadvantages of liquid biopsies. So I've just highlighted here some of the advantages are that liquid biopsies are highly concordant with tissue biopsies. So if you detect an EGFR mutation, for instance, in a patient's blood, they almost certainly have that EGFR mutation in their tissue as well. As I mentioned, liquid biopsies have a rapid turnaround time, usually 7 to 10 days. They're minimally invasive, so, they just require a simple blood draw, and they can be repeated over time. Some of the disadvantages is that you can't assess for non-DNA biomarkers. So you can't assess for someone's PD-L1 status, for instance, using a liquid biopsy. There can be increased costs associated with using both a liquid biopsy and a tissue biopsy approach. And then we do see false negatives with liquid biopsies. So when you're doing a liquid biopsy, you're not actually taking a biopsy of the tumor and performing sequencing looking at specific mutations. You're really reliant on the amount of DNA that's being shed by the tumor into the bloodstream. And that can vary for a variety of reasons. So just because you don't detect an actionable mutation in a liquid biopsy doesn't necessarily mean that it's not there. It just means that you probably need to then go perform a tissue biopsy to assess for the various actionable mutations before initiating appropriate therapy. So liquid biopsies are often complementary to tissue biopsies. So this is a study that we did a number of years ago looking at advanced non-small cell lung cancer patients that had both tissue sequencing and a liquid biopsy ordered. And interestingly, if we were to just look at the patients that had tissue sequencing, we would identify an actionable mutation in about 21% of the patients. But if we combine both tissue and a liquid biopsy, we identified an actionable mutations in 36% of patients. So the combination of tissue and plasma significantly increased the number of patients identified to have an actionable mutation that could then go on to receive a specific targeted therapy. Another important concept with liquid biopsies is that if you detect a mutation by a liquid biopsy and then treat that patient with a targeted therapy, they have an excellent response to these therapies. So this is what's called a waterfall plot with the change in a patient's tumor on the y-axis, and bars going downward suggest that the patient's tumor is shrinking. And so here are a variety of mutations that were detected by a liquid biopsy approach, and then patients received their appropriate targeted therapy. And you can see almost all the bars are going downward, suggestive of tumor shrinkage and excellent response to these therapies. Targeted therapies is associated with better survival, whether utilizing a liquid or tissue biopsy approach. So this was another presentation at ASCO this year, just highlighting that it doesn't matter whether you're doing a tissue biopsy to assess actionable mutations here in yellow, or actionable mutations are detected via liquid biopsy here in the blue, that whether you detect these mutations in a tissue or liquid biopsy, that if those patients receive a subsequent targeted therapy, that those patients have improved overall survival compared to those patients that don't receive a targeted therapy. So really, this just really hammers home that we really need to use these as tools to better perform comprehensive molecular testing for our patients so we can improve patient outcomes. Now, the other major way that liquid biopsies are used currently is at disease progression on a targeted therapy to look for mechanisms of resistance. And I just want to highlight two patient stories over time. So this is a paper from 2016 that describes a specific patient who had an ALK fusion mutation. And that patient had a biopsy at baseline that identified the EMF4 ALK fusion. They then received crizotinib. At disease progression, they had an additional biopsy, subsequently received a different treatment, and then at progression again received another biopsies, and throughout the course of their care received 4 different invasive biopsies. Now fast forward to a paper from 2018. Here is a similar patient that had both a tissue biopsy and a liquid biopsy performed at diagnosis that identified an EMF4 ALK fusion. They received an ALK therapy, and then at disease progression, rather than have a tissue biopsy, they simply underwent a blood test and liquid biopsy. And in this liquid biopsy, they were found to have then original ALK fusion, as well as in red here, a ALK resistance mutation that confers resistance to ceritinib. That patient was then treated with alectinib and then had a great response, and then had another liquid biopsy at disease progression. And so rather than undergoing multiple invasive biopsies, patients that are progressing on target therapies can now just get a simple blood test to look for mechanisms of resistance. And in fact, now it is recommended that patients progressing on targeted therapy, that liquid biopsy actually be used as the initial approach to look for mechanisms of resistance to better treat our patients. And if those liquid biopsies are then negative, then you can move forward with a tissue biopsy to look for other mechanisms of resistance. Another way to utilize liquid biopsies that I just want to highlight that's been interesting is to improve the timeliness of biomarker testing. And to discuss this, I've just highlighted the non-small cell lung cancer diagnostic journey. So typically patients have some imaging where they have suspected advanced non-small cell lung cancer. They then get referred for a tissue biopsy. This biopsy shows non-small cell lung cancer. That tissue is then sent for PD-L1 testing. And then depending where you are, that tissue may undergo reflex tissue sequencing for biomarker testing, or you see the medical oncologist and the medical oncologist orders sequencing at that time. But often at the first medical oncology appointment, these molecular test results are not available. And so you're often waiting for these results to come back before initiating treatment. And oftentimes, while the medical oncologist is waiting for these results, they might themselves order a liquid biopsy in order to speed treatment along. So we were recently interested about whether performing liquid biopsy earlier in the diagnostic evaluation in some of these patients would improve the timeliness of biomarker testing. So could we perform a liquid biopsy at the time of tissue biopsy? And would that enable molecular test results to be available at the first medical oncology visit so that treatment decisions could be made earlier for our patients? So we recently completed this study and have demonstrated some really promising results in this area. And we'll be presenting these results at the upcoming World Lung Conference in September. So some major takeaway points that I just want to highlight are that comprehensive biomarker testing is crucial so that each patient can be considered for personalized therapy. Liquid biopsy is a minimally invasive means to assess for both actionable and resistance mutations. It's an easy, fast way to rule in a mutation. If actionable mutations are detected by liquid biopsy, use of targeted agents has similar response rates to tissue testing. Liquid biopsies are not an effective way to rule out a mutation. As I described, we do see false negatives from liquid biopsies. And so if a mutation is not detected by a liquid biopsy, it's important that a tissue biopsy is performed to look for associated actionable mutations. And then, as I mentioned, is now the preferred first step in identifying resistance mutations in the setting of progression on targeted therapies. And so these are just the current uses of liquid biopsy. And as our next speaker will attest to, there's really some very exciting and emerging clinical applications of liquid biopsy that are coming down the pipeline that I think will be really beneficial for all of our patients. So with that, I want to thank you for your time, and I think we'll have some extra time for questions at the end of the session. So thank you so much.